Okay, welcome everybody. Thank you for joining us today. We're really excited to continue this webinar series. For those of you who don't know, I am Barbara Campbell and I am Executive Director of the Dalton Foundation, and the relink.org project is definitely one that's near and dear to our heart that we've been working on since 2017. We also have Bill Pica with us today, who is our statewide data coordinator, who helps us a ton keep all the data up to date, organized, and adding new data in as well. So we're really thankful for all the help he provides. And we also have with us today Dr. Borland with Basecamp Recovery. We are privileged to work with the Basecamp team on a project that we will share a little bit about as we get started. And while I do share a little bit about that, as Dr. Borland said, please be thinking of questions you have, concerns about substance use disorder. For those of you that don't know, relink.org is an online tool started in 2017 that focuses on providing resources for anyone in the state of Ohio for free surrounding substance use disorder, reentry after incarceration, human trafficking, basic needs, and then all behavioral health in general as well. We really just want it to be a free public service tool for everybody in Ohio to be able to access anything they may need, whether it's along a recovery journey, a reentry journey, or however these paths may be. So it's our job to keep it up to date and as comprehensive as possible. We also like to provide these educational webinars where we bring together professionals on a different given topic that's on relink.org to foster collaboration and learning. So this is part of that series. And one of the things we're focusing on in 2022 is families, and that's where this project originally got started. We will be adding family resources to relink.org. It will have everything from adoption to foster care, youth programs, youth engagement. So all that's coming soon later in 2022. And another part of that project is to work with families at a closer level to really understand how the epidemic is impacting families, but well, we know it's impacting them. But how can we help mitigate some of the challenges that families are facing? And that's where we came into partnership with Dr. Borland and the Basecamp team. Excuse my slides floating here, which is this Begin the Climb website. We've wanted to work with them to provide a tool, an easy to use, not cumbersome tool to help support and educate families as they navigate through the challenges of living with or caring for someone that's struggling with substance use disorder. So the Basecamp team has designed some training, and really, Dr. Borland, I want to turn this over to you because no one explains it better than you do. I want to have you explain it a little bit. If you were on our webinar last month, you know that we kind of went through this site in great detail. We won't go through it in great detail today, but we do want to create awareness about it being here. And then Dr. Borland, my first question I was going to ask you today is basically what you've seen in the past month since this was launched.
Yeah, absolutely. So the website is beginyourclimb.com. And what we've created is sort of born out of the coronavirus pandemic. I used to do family lectures at previous treatment centers where I worked, and we did those every other weekend. But when COVID was really bad, I couldn't give out those lectures. And so we tried to come up with a way where that useful information could be presented to parents or significant others who may have a loved one who is struggling with addiction or mental health disorders. And so we came up with Begin Your Climb. It's an educational platform. It's got about 4 lectures in it right now. Each lecture is between 7 and 15 minutes long, so not very long at all. You can do the entire course in maybe an hour or so. It does have a pre-test and a post-test. There's no fee, there's no credit card required. It's just create your login, and then you're free to do the course and return back to the lectures as you see fit. What we've seen is over the past month, I've seen a much larger amount of traffic that's been going through our site. I've also continued to see the relationship that we were hoping to see, which is everyone's doing the pre-test. They're sort of averaging around 50 to 60%. And then through the post-test, we're seeing numbers that are around 80 to 90%. So that's really, really helpful, because I think that that signifies that we're matching the content to the test questions that we brought up, which are ultimately our objectives for what we would like you to learn from this small set. So beginyourclimb.com, and just create an account, and then you'll go through about 8 different items, which is like the registration, a welcome page, the pre-test, each lecture, a post-test, and then a satisfaction survey at the end. And if you do complete it and you go through all of those options, you will actually be able to print a certificate at the end. So that's Begin Your Climb, and we're seeing increased traffic. I love it. We've had great comments, great feedback, and I'm really excited about how far the project's gone in just 1 month.
Yeah, I think our goal was what, like 25, and you definitely greatly exceeded that in just 1 month. So yes. I was really excited to hear about that. Can you really quickly, because I don't have my account number with me. I do have an account, but I don't have it handy to log into. Can you briefly go over just kind of what topics? Because I know some of the things, you know, that are important, like not only for the state of Ohio with addressing the stigma, but also just the really common things like enabling and things like that that families deal with are addressed. But can you go over the topics really quickly?
Absolutely. So the first video is all about stigma and where it originated. And we really take a historical look back through time to the beginning of sort of the time period where we begin to talk about alcoholism, and then how different varieties and modes of treatment, as well as viewing it as sort of a moral failing, how these different models have brought up into some of the stigma that we're seeing out there today, whether it's, you know, that you're a weak person or that you're a bad person. And those are the reasons why you have drug addiction or alcoholism. Next, we go through an explanation of why is this a disease. It's actually been categorized as a disease for alcoholism, I believe it was the 50s, and for drug addiction was the 70s. A lot of people think that it's a brand new concept, but it's actually been around for decades. But I go through the explanation of the disease model, why people with substance use disorder struggle when they use substances versus members of the general population are able to just put substances away without any difficulty. Third, there is a lecture that is based on the diagnosis and how to make that diagnosis. It's 11 different criteria. And the reason why the diagnosis piece is on there is because if you have 2 to 3 of the criteria, we're talking mild disease, 4 to 5, we're talking moderate disease, and 6+, we're talking severe disease. What we see on the ground, unfortunately, is most of the people who are coming into treatment are already at 11 out of 11 criteria. And so I'm putting those criteria out there to sort of make everyone aware that, hey, we could probably diagnose this way sooner than what we're actually doing. And if we were able to do that, imagine how our success in treatment and all the consequences that we might prevent for someone and their families if we made that diagnosis earlier. So I put that out there to understand how we as clinicians make that diagnosis every day. It's nicely explained, and you'll literally be able to diagnose with the best of them after watching that video. And then finally, we have the parent family lecture. And it's a great series where I sort of walk through various concepts as well as some misnomers. We talk about things like, well, because they're doing this, because they can't stay sober, obviously they don't love me, or that there's some something inherently wrong with my loved one and they're broken and they'll never get better. Or, hey, they went to detox for a couple of days. Shouldn't they be better by now? And we address some of these common misperceptions, as well as we talk about enabling versus support, independence, and the importance of the family and significant others making sure that they get some treatment too. Because unfortunately, this disease, the closer that you get to it, the more likely it is to rub off on you. And so we go through and discuss options for family members and significant others to get some treatment as well.
Thank you, Dr. Borland. And yeah, for those of you that have gone through it, thank you. And if you haven't, I highly suggest you check it out. And I know on this call, we have both professionals that work with people struggling with substance use disorder. And then we also have family members. And then we also frequently have people that struggle themselves. And I think what I love about this program is its brevity, but it's the amount of information that's kind of crammed in a short amount of time. When I think about it from watching it as a family member that is watching someone struggle, a bite-sized piece like this is what you need. It's really hard to commit to sitting down to hours and hours of education. While it might be needed, it's just hard to make that commitment. This is such a smaller commitment. And then when I think about it from like the social worker or the provider perspective, I think about what a wonderful tool this would be to sit down with someone and show them a video that's really well done, and have that be a starter of conversation for a session that can prompt so much more conversation. So the fact that it's bite-sized like this, I think is really, really good for providing comfort and providing a tool for those that are professionals. So if anyone has any more questions about it, wants to learn more, I know that Dr. Borland and we're always looking for feedback too of how do we make it better. And so I know that that's always welcome as well. So
absolutely. We've already made some changes based on some feedback that we've received. So we appreciate that feedback. We don't know what's wrong with it unless you guys tell us. And the other great thing is this is a small bite size. We've actually got about 16 other videos that are done and animated as well. So we're kind of seeing how this rollout goes in partnership with the Dalton Foundation and relink.org, and kind of decide down the road if we want to expand it or bring in some other platform and see where we go.
Yeah, that's great. So thank you again, everyone. We do appreciate any feedback or comments you have, because same with relink.org, that's how it evolved into what it was focus groups around the state and people telling us what they liked and what they hated. And we still do that, but it's been incredible, the information we get, things we never think of on our own. So it's greatly appreciated. So now we really want to turn it over to everyone here and hope that you have some questions. Now we can do this two ways. I can allow everyone to speak, which I'm very happy to do. But if for the moment, while I take everybody off of mute, which I'll do in a minute, if you want to raise your hand real quick, I can do you first so I can get to everybody. It might take a minute for me to allow everybody to talk. So if you have a question, raise your hand. And I'm going to basically pull people into the meeting. Does anybody have a question you would like to ask?
You can also type them in the chat if you have a question. You can do that too.
Yeah, can do that as well. Oh,
that's less scary than talking.
It can be. Robert has his hand up. Robert, I can go ahead and let you speak.
Yeah, hi there.
Hi, Robert.
I just signed up for an account, so I'm really excited about this training. But having a diagnosis of a disease or an addiction, how does that deter the let's say the person in recovery from gaining confidence?
I guess you're saying that because they have a diagnosis of substance use disorder, does it cause them to feel some sort of way about that? I really, when we talk about sort of the diagnosis and the substance use disorder, I like to think about, what about diabetics? We call them diabetics, and there's not really this emotional feeling that's associated with it. And I view it the same way with people who have the diagnosis of substance use disorder. By identifying substance use disorder, you're far more likely to actually get into some sort of treatment. If we delay, like what we're currently doing, where stigma says, don't call them an addict, don't call them an alcoholic, they're going to get mad, or you might ruin their life. What we're really doing is we're actually prolonging the amount of time until they can actually get into a treatment scenario. Where if we got them into treatment much earlier, we'd have a much higher success rate.
Oh, yeah, I'm sorry. So I guess I'm referring to, I work with people getting out of jail and prison. So a reentry ministry. And what just happened 2 weeks ago, which I never would have ever accepted before, is I had somebody come into my home, which I said I would never do, met him in jail. He's been to several treatment centers. So this is not an uncommon routine. I don't want to call it that, as being callous. And so the whole idea is, how can we stop this cycle of going back? 3 guys that got out of jail are currently getting back into another program. And so that's what I meant about, do you see is, how can we address that? Or maybe your program does do that?
That's a great question. And it's a question because the field of addiction medicine is completely unlike other fields of medicine right now. If you go into a hospital that has a cardiac center, there's all of these standards that you must meet. And hospitals are governed and regulated so tightly on all of these standards that pretty much everyone who can claim that they have a cardiac unit is really meeting and exceeding the standard of care for the treatment of, let's say, chest pain. Very different in the field of addiction medicine. There's very little oversight. There is a set of evidence that is released by the American Society of Addiction Medicine. They have a manual that they release every other year with all of the updates and treatment recommendations. But unfortunately, most places don't even know what that is. It's sort of a wild, wild west situation where, we do some kind of counseling and we combine it with some case management. But ultimately, there's really a very set way that you treat substance use disorder, and that's a combination of medications, clinical counseling, and management of case management for an extended period of time. And it's not necessarily, going to detox and then bouncing out and then not doing any more treatment. So it's unfortunate because a lot of people might actually go with the best intentions that I'm entering treatment, I'm going to get the best care. And unfortunately, it's very rare to get the best care. And so until we start living up to the standards of other fields of medicine, it's unlikely that we're going to see this problem, particularly like for one, going to detox. Detox is not treatment. We go over that in one of the videos. It's withdrawal management, and it lasts for a handful of days. You receive no treatment, and then when you leave, you're not really connected to anything. So unfortunately, you sought treatment, they said they gave you treatment, you leave, but nothing changed. And the American Society of Addiction Medicine actually recommends that you don't do that. You don't do detox unless a person is going into treatment directly from the detox spot. So there's other examples from the American Society of Addiction Medicine where they say don't do these things, but yet we see it's commonplace throughout the field So unfortunately, that's one of the areas that we have to work on, is improving standards and setting a higher standard for the field of addiction medicine. And then the incarcerated population, that's a whole other half-hour talk. We are we are intentional about helping the incarcerated population because they are extreme risk. They typically don't receive any significant treatment while they're in. And so it's like diabetes. We put them in a cage and then we let them out. It's not like their diabetes got better while they were just sitting there. In fact, it probably got more out of control. Well, that's what their substance use disorder is doing. And then we turn them back loose and we're shocked that the drug addict went and used drugs. It's like, well, what would you expect? We have medications that prevent cravings, that keep people from using, but right now it's a fight to get these medications for those who are leaving incarceration. I don't know why you would. It should be just a basic need. A person who is released from incarceration on MAT, medication-assisted treatment, is 129 times less likely to die in the next 2 weeks than a person who is released on no medication. So it's really sad because this incarcerated population, they're very, very vulnerable. All right, I'll stop there.
Thank you. We do have a couple more questions that have come in. I see Bradley, you have your hand up. Do you want to go? And then I want to get to Rebecca's question as well. Bradley, are you there? Well, while we wait for Bradley, Rebecca had asked a question about how do you handle co-occurring disorders, especially those that have pain?
Oh, great question. Great question. When we're looking at addiction medicine and treating substance use disorder, there's a variety of common things that we come across. Those with substance use disorder have difficulty not only using substances that release dopamine, but also engaging in behaviors that release dopamine. And so some of these behaviors that they may struggle with include eating disorders, self-harm, gambling disorder, gaming disorder, sex addiction, pornography addiction, financial spending. And so you really have to have sort of this wide picture of what all is going on with the patient. In addition to those disorders, you have to also consider mental health and other personality disorders, as well as physical health that may also be contributing. So it's a very broad area that you're looking at, and it really requires simultaneously treating each one of these over a period of time. If you focus on one and you get it going really, really well, and maybe they've got 3 months of recovery under their belt, but now their bipolar is unmanaged and they go into a manic episode and they end up using because of that, that can crash all the progress that you've made. So you have to be very careful about trying to make sure that you keep your eye on all of those spinning plates and treat each one individually and simultaneously. We do have psychiatric nurse practitioners here to assist with mental health. We have family practice nurse practitioners, as well as we don't have anyone who specifically handles pain, but I will tell you that utilizing Suboxone for a person who maybe was on a significantly high dose of oxycodone, when we transition them off the oxycodone and onto the standard dosing of the 16 milligrams of Suboxone, their pain is actually well controlled, surprisingly, because I would think that, oh, they're on this high dose of oxycodone, Suboxone is not going to make any dent in this. But I've seen actually very, very good pain control with Suboxone.
Great, thank you. Yeah, that's challenging with all the co-occurring disorders and how you have to kind of play a really great balancing game. You have to do it. Otherwise you're going to fail, right? So that's great response.
So Bradley, I want to respond to his. So Bradley, that's able to be said. He brings up the question of those who have a diagnosis of alcohol use disorder or opiate use disorders are able to receive Vivitrol prior to being released. And yes, that's true. We go into Jackson Pike where there's about 1,700 people and they have a Vivitrol program. It is limited to 10 people. Most of these 10 are waiting to go to prison. They've already been sentenced. They're just waiting until they actually get a sentence to go to prison. So of those people who are in the Vivitrol program, we lose about half of our 10. So now we're down to about 5. And in a population of 1,700, it seems nice to be able to say, yes, they're able to get Vivitrol, but they're not. 5, 6 people might get Vivitrol before they leave out of the 1,700 that are there. It's something very personal to us. We enter the jail systems every Friday, and we talk with patients about coming directly from jail to base camp so that they can get on a medication. But unfortunately, yes, they do provide some medications in jail and prison, but it's never to the level that we need. It really
Why is there just 10 Vivitrol? What is the number 10? How does that number get determined?
So I think it has to do with the number of samples that they can get at one time. Because obviously when you go into jail or prison, they stop your Medicaid benefits. So all of this is sort of on a donation type basis.
Okay.
So basically 10 is about the right number of the number of samples that you can have at any one given time. It would be great. Another area that might fix this would be allowing people to get back on Medicaid like 2 weeks prior to being discharged from leaving incarceration, because then their insurance would actually pay for these medications. And so everyone might have a chance at being eligible for that. I also, I don't know any other programs that are currently going into the jails or prisons. We had to absolutely fight to get into Jackson Pike. It took over a year. And like I said, we're only allowed to interact with 10 people. So I don't know of any significant incarcerated programs that are there.
Thank you. Bradley, does that answer your question? Did you have any follow-up to that? I didn't want to lower your hand until I knew that we'd gotten everything.
I don't think you can hear me. Can you hear me?
Yeah,
Yes.
we can now.
Oh, okay. So yes, and you're right, between the county system and the ODRC 28 institutions, and with the amount of demand and need, it's just not enough. But there are things that are happening now within the medication assisted treatment realm within the Ohio Department of Rehab and Correction, and also with these opioid treatment programs being implemented in 4 of the institutions. One of the things that they'll have to navigate is when somebody's they're opioid naive because of being incarcerated for a certain amount of time. And do you then reintroduce opioids back into their system as far as MAT? So there's a lot of uncharted territory there for a doctor and patient to discuss.
That's a fantastic one of those. What kind of a decision? Because you could easily make arguments both ways. The way that I would look at it, as I view the medication as a form of treatment. If a person has had adequate treatment, then they don't need medications. If they've had no treatment and then we just turn them loose, then I would say it is beneficial to reintroduce an opiate into their system, once again, making them physically dependent upon opiates again. Because if you have no treatment while you're in there, then your chances of success are so low that I think the risk versus benefit of starting another person back on an opiate is worth it.
Thank you
Great
for
points.
a few minutes to have a discussion with me.
Absolutely, Bradley. Great question. Great thought. Those are excellent questions. And I like the thought-provoking one there too. Fantastic.
Yeah, these are really great questions, and honestly, things I've never thought of. Does anybody else have any questions they'd like to ask? I do have some to ask.
Oh, Robert
Yeah.
asked about Sublocade.
Mm-hmm.
And
Yeah, go ahead.
Robert, it's a great medication. So it is an injectable form of buprenorphine, which is the opiate that is commonly found in Suboxone. It lasts 30 to 45 days. It actually lasts a little bit longer than that because it takes a while to sort of wean back out of your system. But in general, it's a monthly injection. It breaks the habit of I've got to carry my medicine around with me all the time, and I take my medicine all day long. It sort of breaks those habits. It also is great for diversion because you can't divert it. You can't sell, the Suboxone films that otherwise you might be carrying around. And it's great for people who are in sort of controlled living environments or sober living environments because they don't have to worry about this closet full of everyone's Suboxone. If they're on the Sublocade shot, there's no controlled substances in the house, and it works out beautifully. It's also a significant preventer of overdose. Buprenorphine in and of itself significantly prevents overdose due to the blockade of opiate receptors as a partial agonist. And so Sublocade and Suboxone both are encouraged given their ability to prevent lethal overdose.
Thank you so much. Keep thinking of your questions and either type them in the chat or ask or raise your hand and we can definitely let you speak. Dr. Borland, I had a question for you. I know we get this a lot, so because we do a lot of presentations and we get what I call our frequently asked questions. And I know you do an in-person on Sundays with your patient population and with their families. You do an Ask the Doctor series in person. And so I was just curious, what are some of the most common questions you are getting from these individuals and these families?
Yeah, so probably the number one is enabling versus support. And I try to make it pretty simple to understand enabling versus support. So if this person has a diagnosis of substance use disorder, ultimately they will not get better without medical treatment. It's a medical diagnosis. So therefore, like diabetes, if they don't seek any treatment, their diabetes is not going to get better. It's a chronic progressive disease that gets worse over time. So when you want to consider, am I enabling or am I supporting? The major difference or the question you want to ask yourself is my behavior making it more or less likely that they will go to treatment? If I'm making it less likely that they will go to treatment, that's enabling. So if I'm making their life more comfortable, as in I'm paying for all their food or their gas money, or I'm helping them out with some money that I know they're spending on drugs, or I've got them in my home and I keep, doing their laundry and cleaning up after them and making sure they've got a place to stay. All of these things make it more comfortable for them so that they are less likely to actually become uncomfortable enough that they seek out treatment. So the question for enabling is, am I making it more or less likely that this person is going to actually go out and seek treatment? Support is a great topic because there's a correct way and an incorrect way when it comes to support. And this is where you have independence versus codependence. Support does not mean that you are sacrificing yourself to help another person. Support means that you are there to provide the correct item, behavior, or need while not hurting yourself in the process. If you are hurting yourself in the process, that's when we're starting to talk about codependency. for instance, let's talk about support of, hey, my daughter is out on the street and I need her to go to treatment. She's reaching out to me. What should I do? Well, in that situation, probably the only thing that you can do is go down there and offer to provide them with like literature for going into a treatment center and then stepping back away. If you were to do the opposite and say, I'm going to help you get into treatment, now you've just attached yourself to a major problem, because this might turn into your entire life being consumed by a person that maybe doesn't actually want to go to treatment. And so now you're trying to drag them places. They don't stay. They steal from you and take advantage of certain things. If you are codependent, this can ruin the life of family members. You have to be able to remain independent, where that is, I'm providing help, but not at my expense. So, hey, my daughter's out on the street. She asked for help. I took a base camp card out there and I said, this is a great treatment center. Call and get in there, or walk over there and get in there, because they will help you. And that's the best thing you can do for them. And then step back away, because now it's the responsibility is back on them, versus, hey, I'll work to get you in treatment. Oh my gosh, this could be all kinds of interesting pursuits for you, and then you become a probation officer and a drug tester and a counselor, and it's just you have to be able to recognize that line, because you deserve to have a happy life too. You know, you're equal to everyone else. And so independence and avoiding codependence allows everyone to remain healthy.
That is just such excellent advice. I bet you everyone on this call at some level can relate to what you just said in some way. You know, obviously it could be very personal, but even there's always an extended family or a friend or someone that's gone through something where you find yourself in this position of, am I enabling? Am I becoming codependent? And the line, you can cross it so easily and so unintentionally with all the right intentions. Yeah. I just think of some own examples in my own life of when I have crossed the line, and this like, oh, it's such a good reminder of that. And I thank you for that. Like I said, that's just very convicting for me personally, of just like, because you care so much when it's someone you love, and it's just so easy to cross that line, you know, and you're so invested in the outcome, right? And it's an outcome we can't really control. So,
exactly. And I think that's the ultimate word right there that you used, is control. Unfortunately, this is a person that without treatment, their life is getting much worse. And so if you attach yourself to them, you can expect to ride the ship down. But if you stay independent and provide that help, recognizing that you can't control them, you can do everything, give them the card, tell them what to do, but ultimately leave your idea of trying to control what they're doing aside. I think that's a great way to look at it.
Yeah, thank you. There was one question that came over as well. I think a couple of us come over. Sorry, for those of you, I have a Zoom challenge today. There's one question about withdrawal, that they had heard that withdrawal symptoms are less when a person is being tapered off of Suboxone versus being tapered off of Suboxone. Is that true in your reality, Dr. Borman?
Karen, I can't specifically say. I have not at this point in time weaned very many people off of Suboxone. I do believe that absolutely it will be easier to come off of Suboxone than Suboxone, particularly because of the psychological approach of, I take my medicine. If I don't take my medicine, I get sick. It breaks sort of that thought process. And so weaning off of it so slowly over a longer period of time, I believe is going to be far superior than just trying to come off of Suboxone in and of itself, because you're still very attached to that idea of, I take my medicine and I'm okay. If I don't take my medicine, I feel sick. And so I can't give you a 100% answer on that, but that's my estimation.
Great, thank you. That led me to one question that I was thinking of too is, and I hear this a lot too, and as a pharmacist, I was asked this a lot when I was practicing, is how long does a person need to be on MAT treatment? And I mean, I know there's not one answer, but I'm just from your perspective, what do you see, or what is the prevailing thought in addiction medicine on that?
Absolutely, great question, because it's all over the place. Here's the way I look at it. What is success? Success is that a person is not using illicit drugs and they're putting their life back together. They're generally happy. They can work a recovery program. They can hold their job. They can be productive members of society. And so if they are utilizing a medication that is helping them to do that, I think that they can stay on that medication for as long as they want. We do not, for some reason, with Suboxone, we feel that it's almost a bad thing, and you must come off of it as soon as possible. I think that idea comes from people viewing it as a drug and viewing it in a negative light, when in actuality, people's lives are so much better, and they are so, the likelihood of successful recovery is so much higher with Suboxone that if they don't want to come off of it, I'm not going to force them to. It's like, hey, diabetics, you got to come off insulin. We would never do that. Or you've got to come off your antidepressant because we feel like you should come off of it. We would never do that with other forms of treatment. I can tell you with patients that do want to come off of it, I do a very simple little test with them. I take out a sheet of paper, I draw a line up the middle, and I ask them, what is a perfect recovery program look like? And they'll be like, well, taking my medicine, individual counseling, group counseling, going to meetings, got a sponsor, working the steps, doing volunteer work, community service, and all of these things. Then I say, what does your recovery program look like? And oftentimes it's like, I go to a couple groups and some individual counseling, and I take my medicine. And so I ask them, so if we take the medicine away from this perfect recovery program, that's just a very small portion. And so they'll likely have plenty of support to succeed. But if we look at your recovery program, that's a major, major, major component of it. And I don't know if I feel comfortable taking away 1/3 of your recovery program and expecting you to do well. That oftentimes is a very good way to help people come to the understanding that if we're taking away something from the recovery program, we need to make sure that we have plenty of other things in the recovery program to withstand that.
Great answer. Thank you for doing that. That is actually a really helpful way to think about it, of what other support they have. And Stacy had a question and a comment about that. I'm sorry, I can't tell y'all how many Zoom problems I am having on this end today. Every button I hit, it does not do what it's supposed to. Can you read Stacy's question, Dr. Borland, or her comment about I can only read half of it and then it's gone.
Yes. So Stacy, actually, we incorporate AA and NA a ton here. We follow the new medical model of treatment combined with the AA model of treatment / NA model of treatment. The problem is just alone, NA and AA is not very successful. I think the success rate's around 8% or so. But when you combine it with medication and some treatment and some counseling, they have fantastic abilities to allow people to really enter into the life of recovery. We think about, hey, I'm not going to use drugs and alcohol. That's just a small, small portion of what recovery is. Recovery is redeveloping that spiritual or quality relationship with oneself and others. And that's where AA and NA can really come into play. They have the 12 steps, which is basically a how-to guide of learning to love yourself again and learning to build a life in which you are so content and happy that the use of drugs and alcohol just doesn't even make sense anymore. And so we do encourage it. We use the NA step books for working steps 1 through 3 with our patients while they're here. And obviously, as part of their transition into outpatient, they do have to have a sponsor and continuing to work their steps with them and attending several AA meetings per week. We do also provide, I think right now we're doing 3 AA meetings a week here in our facility for our patients. So I'm a firm believer. I'm in recovery myself. I'm a firm believer in AA and NA. The steps saved my life. And so I'm glad you brought that up.
Yeah, thank you, Stacy. And I think I can see some questions now, so I'm happy about that. But I think you also bring up an excellent point that I think probably most people have heard, but I think it's just really worth reiterating about recovery being a multifaceted thing where nothing is everything, but everything is important, and having people get all those tools to help on the recovery process. Ashley has a question. What is your insight on engaging pregnant women using substances early in their pregnancy? We have seen a recent trend of receiving new referrals for pregnant women who are in their 3rd trimester, and these women are really struggling with being substance-free during treatment.
Yeah, Ashley, you're absolutely right. And it's a trend that we're seeing a little bit more here recently as well. Absolutely. We attempt to keep patients off of illicit drugs. And so oftentimes that involves the use of Subutex, which is a buprenorphine only product. It just does not contain the naloxone. And if we can successfully get them onto buprenorphine, fortunately, that's a much stabler state for their body to be in, as well as for their baby. And when you're using like street drugs, you're bouncing all over the place with intoxication withdrawal, that it's pretty hard on the developing baby. But getting a person onto Subutex is very protective against maternal overdose, as well as neonatal withdrawal syndrome. If that person continues to breastfeed, they actually found that is the most successful method of treating neonatal withdrawal syndrome, is if their mom continues to use their Subutex and breastfeed, and that helps with neonatal withdrawal syndrome significantly. But ultimately, we've got to get them off illicit drugs. The drugs are too lethal, they're too dangerous, and it's too hard on the baby. And so we've got to do whatever it takes, medication-wise and counseling-wise and or inpatient-wise, to make sure that moms are not using during treatment or using during pregnancy.
All right, thank you. I know that's another common question I think you get, Brian, Dr. Borland, is on how to treat and address the complications with pregnant women. So that's a great question to bring up today. There's a question about being muted. I believe everyone is muted. We're not having any issues. So to my knowledge, to what I can see, I think we're all good. You can keep raising your hand and or unmute yourself and speak. Bradley had shared, for those with alcohol use disorder, you can see the results of the Cochrane study, 12-step facilitation and outcomes. Oh, that'd be very interesting. And he puts the link there. So thank you.
Yes, thank you. Appreciate that, Bradley.
All right. Are there any other questions that anybody has? Dr. Borland, back to you just for a quick, any other of the common things you're seeing, even recently at your facility that's maybe something new or maybe something that, I don't know, maybe surprised you? You've probably seen so much, but.
So I think some other common things that we talk about is why is this a disease and what's really wrong? The way I like to go about it is comparing to diabetes, again, the chronic disease model, in which basically a disease is a organ plus some defect that results in symptoms. With diabetes, the organ is the pancreas. The defect is you don't produce enough insulin, and the symptoms are all related to elevated blood sugar levels. For addiction, the model for it would be The organ is the brain. The defect is an abnormal dopamine response. And so this abnormal dopamine response is that when a person, or the way that their dopamine reward system is supposed to work, is that evolutionarily, over a period of time, your reward system rewards you for doing things that promote survival. Include such things as sex, food, community, shelter, hygiene, and these all promote the survival of the species. And so whenever you engage in these activities, you get dopamine for it, and this increases the likelihood that you're going to keep on doing it and promotes the survival of the species. Well, imagine a person with a substance use disorder who, when they use drugs and alcohol, for some reason, they get dopamine, very similar to people without substance use disorder who get dopamine from all of the normal ways. So those with substance use disorder, they get dopamine released by the same behaviors that we discussed with people without a substance use disorder. But if they use drugs and alcohol, they get a significant increase in the likelihood, a significant increase in the amount of dopamine on the form of 10 to 100 times. And so this sort of reprograms the brain because it equates dopamine with survival. And so it looks at this setup and it says more dopamine equals more survival. So if I'm getting all of this dopamine from drugs and alcohol, I don't even want you to consider doing the other behaviors. Let's just focus on the most efficient and effective way to survive. And so what do we see ending up happening with substance use disorder patients, drug addicts, alcoholics, is oftentimes they're not engaging in sex. They often go without eating. They don't take care of their hygiene. Instead of being interactive in a community, they're isolating. And if instead of even focusing on shelter, they're being okay with being homeless. And so it all of a sudden sort of clicks. This is a physiological process by which their brain has unfortunately found out that they can get a lot of dopamine from drugs and alcohol, and therefore, in its mind, it is promoting your survival by utilizing these things that provide more dopamine. So nothing is more important than survival. So this is where the sort of irrationality comes in when you look at alcoholics and addicts and the behavior that comes along with it. As humans, we want to look at something and have it make sense. It's just sort of the natural way of things. We want to look at something and it's like, oh, that makes sense. I can see why that happens. With drug addiction and alcoholism, it doesn't make sense. You are hurting yourself. You know you're hurting yourself, but yet you continue to hurt yourself despite blatantly having evidence that you're hurting yourself. That doesn't make any sense. When we actually view it in the model of drugs and alcohol providing so much more dopamine, it does make sense because it's their brain that's saying, we are surviving. No matter what happens to you, no matter what happens to your body, physically, spiritually, emotionally, none of that matters. As long as I'm getting the drugs and alcohol, we're surviving and we're winning the game of life. So it begins to make sense when you look at it from that sort of lens, that their behavior is simply the result of a physiological process by which their brain is confused. Instead of pursuing the real things in life that promote survival, it pursues things that cause poor physical health, poor survival, and all of these other behaviors. So that's very frequently one of the questions we talk about, like, why do people have substance use disorder? Or, hey, it was their choice. They did this to themselves. Well, not really. They did not decide whether they were going to have this dopamine response to drugs and alcohol when they first started using drugs and alcohol. They probably started using drugs and alcohol just like everyone else around them. And then in the process, for some reason, over a period of time, since they received their dopamine from drugs and alcohol, to the level that they do, their brain reprioritizes, puts it at the top, where everyone else who doesn't get that dopamine for alcohol or drugs, they're able to just put it down and carry on with their life. So yeah, they made a choice, but it was very similar to the choice that almost every, 13 to 16-year-old person makes, whether it's alcohol or marijuana or whichever drugs that they encounter first.
That's just such a great explanation, Dr. Boyne. We appreciate that. Every time I hear it, it's just more and more convicting and clearer. So thank you so much for sharing that. And Robert had a follow-up question. Is there a blood test that can measure dopamine levels to show that they are higher to help confirm a diagnosis?
Not that I know of offhand because what we're really talking about is the dopamine levels that are in the reward system. Yeah, so it's actually, we're talking about dopamine coming from like the substantia nigra, going through and ultimately ending in the prefrontal cortex. There is imaging though that they can do. And there's some very fascinating imaging that they've done where it's they've sort of tagged dopamine response in the brain, and then they've compared people's dopamine response, like healthy subjects and their dopamine response, and then someone using methamphetamine and their response. And so there's some pretty interesting stuff there, but for an actual blood test currently, I don't think it would adequately represent the dopamine that's going on up in the brain.
Yeah, I've been asked that before myself, and it was the same thing. It'd be really hard to correlate a level in the brain to a level in the blood to really understand that. I think would be a little difficult.
Great question, though. Good thought.
Yeah, it is. Wouldn't it be? That would be great. Or if there was a way to measure it in the brain, but that would not be easy.
No.
Well, thank you all for participating today. I think we had some really great questions. We got to touch on a lot of the really big topics. Just a couple of reminders. We are going to do this every month, bringing on a doctor to share. I think next month we talked to Dr. Borland about possibly bringing on some addictionologists from Ohio State to join us as well.
Mm-hmm.
And so we are encouraging people to share this, to invite others. If you know people personally that might have questions or benefit from hearing these answers, please look out for the invite. It will be near the end of March, so we'll send out the date, but we'll expand it a little bit. And then lastly, just want to remind everybody about the Begin the Climb tool, and hopefully y'all can test it out yourselves, offer some feedback, perhaps share it with some that may benefit from it as well. And Dr. Borland, I'll give you the last word. Do you have any last words to add?
I don't think so. I really appreciate you guys bringing some great questions and some great thought-provoking conversation. And if you have any other thoughts that come up, my email, I believe, is available, brian@basecampmed.com, BRYAN. And thanks again. Appreciate your time.
Yeah, thank you, everybody. Have a good rest of your day.
Thank you.